distance course.
Okay. Hello, everybody. This is Dr. Do you hear my sound? You hear my sound?
Yes, I can hear
Hello?
you.
You hear my sound?
Yes, I can hear you.
Okay, excellent. Hello, everybody. I'm Dr. Abu Obaida. I'm a dentist from Iraq. I graduated from Baghdad University in 2004, and I finished my dental diploma in Cairo University 2009. My major work is limited to microendodontics. Today, I want to share with you very important and interesting in endodontics, which is irrigation. Well, the success of the whole procedure of endo depends mainly on irrigation. As we know, we have a term in endo called cleaning and shaping. In fact, it's shaping for cleaning. We do shaping to achieve cleaning. So the major concern as an endodontist is the irrigation. Let's go inside and see what I have for you in this lecture. First of all, I want to introduce this nice and great innovation from Coxo company. It will solve many problems in irrigation. We will talk about later on. It's called CRCC. In endo, we need irrigation to washing out body cavity or wound with water or medicated fluid. And of course, we need aspiration, which is the suction device. And you also need this irrigant solution to be disinfectant. Objective of irrigation is mechanical, chemical, and biological. So any irrigant should achieve these objectives. No one irrigant can achieve all of these objectives. That's why we use more than one irrigant. We start with the mechanical objective. Mechanical to flush out the debris and at the same time lubricant the canal. As we know, any irrigant can use as a flush, but not all irrigants have the lubricant property. Both flushing out debris and lubrication of the canal will achieve the following. Will achieve the mechanical effectiveness depend on the ability of irrigation to generate optimum streaming force within the entire root canal system. And then we have chemical objective, which is to dissolve organic and inorganic tissue and prevent formation of a smear layer during instrumentation or dissolve it once it has formed. So we need to dissolve organic and inorganic. Organic will be the emission of hypochlorite and inorganic will be the emission of the EDTA. And thus prevent the formation of a smear layer during the instrumentation phase or dissolve it once it has formed. Sorry. By doing so, chemical effectiveness will depend on the concentration of the antimicrobial irrigant, the area of contact, and the duration of the interaction between the irrigant and infected material. The biological function of irrigants is related to their antimicrobial effects. So hypochlorite has antimicrobial effect, and chlorhexidine also has antimicrobial effect. EDTA has not, normal saline has not. Efficiency of root canal irrigation depends on penetration depth of the needle and diameter of the root canal and inner and outer diameter of the needle and the irrigation pressure. If we talk about the irrigation pressure, this is major dilemma in endodontics in terms of irrigation. If we use excessive pressure, you might end up with the hypochlorite accidents. And Coxo company invented very nice tool for irrigation. It depends on passive irrigations, no pressure at all. It makes irrigation and suction at the same time, and also it makes warming for the hypochlorite. Type and orientation of the bevel of the needle. Every needle should be closed at the tip, and there should be side vent at the side of the needle to prevent the extrusion of the hypochlorite and hence prevent the hypochlorite accident. We have many needles in the markets, like this one from Ultradent, and this is one from the PD, Airiflex needle. And also we have many types of syringe, disposable syringe used for irrigations. It starts from 1 mil, 3 mil, 5 mil, 10 mil, 20 mil, or 60 mil, and even 100 mil. The one are used for endodontics, the one with the 5 mil or 3 mil. Personally, I prefer to use a 3 mil because I have little pressure. But the problem with the 3 mil, it is the quantity is not that much, so you have to fill many 3 mil syringes at the same time. One more important thing is to look and watch the tip of the syringe. The one you are using it in endodontics should have a look. Otherwise, the needle may jump out at any times. And this is very serious problem, as it happens once or two in my career. I used a needle, a syringe without a look. So the needle jump out and the hypochlorite come to my face and to the patient face. It was a very bad experience. Remember, when you insert the needle inside the root canal, the needle should be loose. This is the way how to irrigate. Push and pull, push and pull. Never let a needle to engage inside the root canal. Otherwise, the irrigant will go outside the apical foramen and make the hypochlorite accident. So remember, the needle should be loose, and you should use it with push-pull motion. Benefit of using irrigant in root canal treatment: we use it for removal of particulate debris and wetting of the root canal walls, and also use it for destruction of microorganisms and the solution of organic debris and opening of dentinal tubules by removal of a smell layer. And this is very important, and this is the action of the EDTA or citric acid. Disinfection and cleaning of areas inaccessible to endodontic instruments. As we know, the file will not touch all the root canal surface or all the root canal walls. Some areas the file cannot touch, like lateral canal, like loops, like isthmus, like bifid or trifid. These are all anatomies. Most common, the file cannot be reached, this area, unless you have very high experience and skill to negotiate these tiny anatomies with the K file, which is called the scouting. So the properties of ideal irrigant for root canal treatment: it should be effective germicide and fungicide, and this is the function of the hypochlorite. Non-irritating to the periapical tissue. Unfortunately, most of the irrigant solution are irritating to the periapical tissue, and that's why we need to be careful during irrigation. We need to remember that the needle should not bind to the canal wall. The needle should be loose all the time. With the push-pull motion, we need to make the needle shorter than working it with 2 to 3 millimeters. We need to use side vented needle, not opened from the top, and remain stable in solution. And that's why most of the irrigant solution comes in a closed container that does not allow the light or the light or even room light to go through the container. Otherwise, the hypochlorite or any other solution will lose its function. And by the way, when we use irrigant, we need that irrigant to be fresh. So from the container directly to the patient mouth, we should not leave the irrigant exposed to sunlight or room light all the day. And a prolonged antibacterial effect. Unfortunately, the only irrigant that has prolonged antibacterial effect is the chlorhexidine, active in the presence of a blood, serum, and protein derivatives of tissue. And this is the action of the hypochlorite. Low surface tension. And that's why many companies that make irrigants, they compete with each other with adding surfactant. So someone asked, can I use the household bleach, the one that we use from the market? Yes, you can use it, but the things that is favorable for the medical hypochlorite is the presence of this surfactant, which make the hypochlorite with low surface tension and can enter through the internal tubules, not interfere with the repair of periapical tissue. And this is a very important during regenerative process. As we know, when we do revascularization or revitalization, we should give much attention that the irrigant solution will not cross the apical foramen and damage the stem cells which are present there. So Be careful when you are doing revitalization or revascularization or any regenerative process, as these irritants are very irritant and may damage and destroy the stem cells. Not to stain tooth structure, and should be given much attention when we irrigate with hypochlorite and then chlorhexidine. We should separate between them normal saline. In fact, it is better to separate between any irrigants with normal saline or distilled water, but especially with hypochlorite and chlorhexidine. Once it mixed together, it will very bad precipitate and will stain the tooth or tooth structure, even the root canal system. Not induce cell-mediated immune response. Able to completely remove the smear layer, and this is the function of the EDTA or citric acid, and able to disinfect the underlying dentine and tooth tubules, and this is the function of the hypochlorite and chlorhexidine. Non-antigenic, non-toxic, non-carcinogenic to tissue cells. Well, if hypochlorite and chlorhexidine mixed together during irrigation, there will be a precipitate called parachloroaniline, which is known to be carcinogenic for human beings. No adverse effect on the physical properties of exponent dentine, and this is very important. We should not expose the root canal surface for prolonged time of hypochlorite. Prolonged time, like 2 hours, 3 hours, and this may change the properties of the dentine. And it is better to spray between each irrigant with normal saline or distilled water. Dissolution of organic debris, which is the function of hypochlorite. No adverse effect of sealing ability of filling materials. Convenient application and relatively inexpensive. Okay. Why we should remove a smear layer? As we know, microorganisms in the dental tubules may use the smear layer as a substrate for sustained growth. So if we don't remove the smear layer, the microorganism would use this smear layer for growth. And if the smear layer is not removed, it may slowly disintegrate with a leaking obturating material, or it may be removed by acids and enzymes that are produced by viable bacteria left in the tubules, and that enter via coronal leakage. So if we don't remove the smear layer, the enzymes or the acids produced by the bacteria that is still present in the root canal system may disintegrate the smear layer and use it as a substrate, and then this will make a gaps between the filling material and the root canal system. The presence of a smear layer may also interfere with the action and effectiveness of root canal irrigants, and that's why we need final irrigation protocol to remove the smear layer that is produced during shaping, and afterward we will let the hypochlorite to get inside the dental tubules and unreachable areas of root canal system. Removal of smear layer adapt filling material better to the canal wall. If we don't remove smear layer, the filling material might not be adapted very well to the canal system, and this is controversial, and this is not the time to talk about this controversy. Removal of a smear layer enhance the adhesion of sealer to dentine and tubular penetration, and last, removal of smear layer reduce both coronal and apical leakage. Now let's talk about the irrigant used in hypochlorite and in root canal irrigation. We have sodium hypochlorite, we have EDTA, we have chlorhexidine, and we have normal saline. If we start with the sodium hypochlorite, which is called household bleach, as I mentioned before, you can choose the medical one, or you can buy the one from the market. Personally, I don't care. I usually buy it directly from the market with the concentration 5.25%. This is the amount of hypochlorite usually I use for the which could be a little bit lower than this amount, but generally this is almost the amount I use for irrigation of molar tooth, whether it is upper or lower molar. I like to use hypochlorite as much as I can. Irrigant of choice: mechanical flushing of debris from the canal, dissolve vital and necrotic tissue, no effect on any inorganic tissue, and that's why we need to use EDTA. Toxic caustic effect on preapical tissue. Much attention should be given when we are doing revitalization or revascularization, as this irrigant, hypochlorite, will damage the stem cells on the apical tissue, And also one should give attention that the hypochlorite, once it crosses the apical foramen with forcible injection, it may cause hypochlorite accident. It weakens in contact with other materials, antimicrobials, lubricant, and this is very important. We should not introduce any rotary or manual file inside the canal if the canal was not lubricated even with any lubricant like EDTA cream or even hypochlorite accident. Personally, when I use manual file, I like to use the EDTA cream. But when I introduce rotary file inside the canal, I like the canal to have only hypochlorite. And last, it is inexpensive and available, very cheap. The concentration are used in dentistry as textbook says. For example, Mahmoud Turabinjai says the range is started from 0.5% to 5.25%. Personally, the only concentration I use is 5.25%. I would use lower concentration if I have direct pulp cupping or I need it for regenerative process. Also, the regenerative process, it is controversial. There is a controversial thoughts and opinion about the concentration used for regenerative process. The efficiency of hypochlorite can be increased when we increase the concentration. If you want to use low concentration, you can use it, but remember, you need to increase the volume and you need to increase the time. Volume and then warming. If we warm or heat the hypochlorite, the action of the hypochlorite will increase too much. I have heard some studies says that hypochlorite can reach 400% of its efficiency if we warm it to 200%. I'm not quite sure about this study, but I have read it before. Okay, so to increase the efficiency, we need to increase the concentration, the volume, and the warming or heating. By the way, the only unreliable means to heat the hypochlorite is to heat it inside the root canal. Other claims we can heating it outside the root canal, but this is not efficient. And once the hypochlorite will reach the root canal, it will be buffered. So this is a video made by my friend Dr. Muhammad Al-Kuzwini, who shows us the difference when you are using 2% hypochlorite and when you're using 5.25% hypochlorite. As you can see, with the concentration 5.25%, the pulp tissue is almost disappeared. While in 2%, we still have the pulp tissue, half the pulp tissue. So at the minute of 4, almost the pulp tissue within the hypochlorite, the concentrated hypochlorite disappeared, while the one with the 2% concentration is still. And you can see after 9 minutes, still the pulp tissue in concentration 2% hypochlorite is still present. And that's why it is preferable to use concentrated hypochlorite. But if you are willing to use diluted hypochlorite, you can use it. But remember, you need to increase the time and increase the volume. About heating the hypochlorite, as you can see this diagram, the efficiency of hypochlorite will be increased once we heat the hypochlorite. The major dilemma with the using hypochlorite irrigant is the hypochlorite accident. Well, if you don't have such experience, I can tell you did not practice endo. I can tell most or almost any endodontists have done this before. But with experience, one should avoid this in future. One should avoid this in his clinic. The good thing, but before talking about the new tool of Coxo, let's give you some advices and some tips how to avoid hypochlorite accident. As I mentioned before, the irrigating needle must be placed loosely in the canal. Don't let the needle to be binding inside the root canal. Always the needle should be loose inside the canal. Second, once you feel that the needle is binding to the root canal system, please withdraw the needle. Third, special care in canal with open apex. And fourth, to avoid such thing, you can place a stopper inside the needle and put it 2 to 3 millimeters shorter than the working length. As you can see here, the needle is shorter 2 to 3 millimeters than the working length. Now, Coxo company proudly innovate this nice tool or machine. It has multifunction. It irrigates at the same time. It irrigates and it sucks, and then it even heat the hypochlorite. I like it so much, and I still use it in my clinic, but it needs little bit modification to overcome some difficulties with using it. But I think the future is for this device. Very comfortable and very nice, and you don't need to care about the hypochlorite accident. And even you don't need a suction system inside your clinic. It irrigates, it sucks in the same times, and it hits the hypochlorite at the same time. Soon will be available in the market. Let's give you some tips about this device. This is the bottle are used for irrigating. You can put the hypochlorite inside this bottle till the half, and that's simply you can connect it to the device. And this is the handpiece. You remove the ring, and you insert tip A like this way. Very simple. As you see, it has multifunction. We have irrigation button, we have suction button, and we have simultaneous button, irrigation and suction at the same time. And we can accelerate the mode. Short press and start will activate the handpiece. So during the mechanical preparation, we use tip A. This is irrigation and suction at the same time, and even heating. So you can see you don't need suction from your suction of the dental unit. The device has built-in suction system. After I finish the shaping procedures, I will change the tip to the tip B. Insert ring, suction, and you can increase the time. You can use it 30 seconds, 60 seconds, 90 seconds, and 120 seconds. Drying, after you finish, you can dry it. Simply push on the red button, insert the needle inside the tooth, the root canal, and it will suck all the hypochlorite. You might only need 1 or 2 paper points. Let's sit on this model.
Hello and welcome to this video demonstration of CRCC irrigator by Coxo.
Here you can see how the pulp tissue will be dissolved by hypochlorite. If you look at the crown, no hypochlorite is coming out from the tooth structure. As I mentioned before,
it is a continuous flow of
the tool has irrigating and suction system at the same time.
What you can watch here is now we have used a pulp replica and it has been packed into this complex anatomy. The tip A, which is meant for evacuation, of macro debris with a wide bore evacuation medium. What you can watch now is when it is activated in a multifunctional mode, wherein irrigation and evacuation happens
Okay.
simultaneously.
So it irrigate and suck at the same time, and it heat the hypochlorite at the same time. Okay. I will accelerate the video and show you how the irrigant will reach even to the unreachable area, like this isthmus. How the hypochlorite reach the isthmus area and even to the apical area.
Time and again, it is advised to clear this
The good thing is to always give you fresh hypochlorite with heated hypochlorite.
now with negative pressure irrigation, wherein it allows
There is no positive pressure during irrigation,
the solution to be free
so one should not be afraid of hypochlorite accidents. Okay, I will share this video on my account once I finish this webinar.
point of cannula, as you can see.
Okay, this is in vivo.
This video is to demonstrate how to use root canal irrigation and suction system (CRCC).
This video is done by Dr.
It is
Manda.
always advisable to clean the access cavity by pouring sodium hypochlorite. Since this is an automated irrigation and evacuation or suction,
You can see it irrigates
it has got dual mode
and it sucks at the same time.
irrigation and suction. It has got only irrigation mode, and also it has got only suction or evacuation.
So you can use it as
What you're
irrigating
looking at
or suction
is
or both
cleaning
together.
the access cavity in a multifunctional mode where one tip irrigates and the other tip evacuates from the prepared access.
Okay. Now let's talk about EDTA. Okay. To do correct endo procedures or irrigation procedures, you should also use EDTA or citric acid. You cannot do endo only with hypochlorite. As I mentioned before, once you introduce the file will cut from the dentine wall, and the cutting will leave a smear layer, and this smear layer will stick to the dentinal wall, and the bacteria will hide behind the smear layer. So if you don't remove the smear layer, the bacteria will stay inside the root canal system. Unfortunately, hypochlorite cannot do this mission. That's why we need another irrigating solution, which is EDTA. EDTA is ethylene diamine tetraacetic acid. The concentration we use in dentistry in endo is 17%. The major function or the main function of the EDTA is the removal of a smear layer, inorganic component. It does not kill bacteria, does not dissolve soft tissue, vital or necrotic. This is the function of hypochlorite. But the problem with the EDTA may erode dentine with longer time exposure. So one should be very careful not to make the EDTA stay too long within the root canal system. I have heard many times for calcified canal, we can manage it with the leaving EDTA inside the root canal. This is totally wrong. EDTA should not be left inside the root canal. Once we irrigate with the EDTA, it should be flushed. It should be flushed. It should not stay too long inside the root canal. The best time for EDTA is 1 minute. And irrigation for 1 minute followed by final rinse with hypochlorite. Well, it is better to separate between the EDTA and hypochlorite with normal saline, as the EDTA will lessen the effect of the active chlorine in the hypochlorite. So once you irrigate with the EDTA, it will remove the smear layer. Flush out the EDTA with normal saline or distilled water, and then use hypochlorite. And this is the better. You can use hypochlorite without separate them, but this will lessen the effect of hypochlorite. Citric acid is effective for removing the smear layer. So citric acid is almost the same as EDTA. As you can see, this is with electron microscope. You can see how the smear layer are blocking the dentinal tubules. The A photo is the smear layer blocking all the tubules. The B photo, after flushing the root canal system with the EDTA. As you can see, we opened all the tubules. This is the magnifying. As you can see, before using EDTI and after using the EDTI, we open all the dental tubules. Now, time for hypochlorite to go inside the dental tubules and reach unreachable area of the root canal system. Chlorhexidine. Chlorhexidine, it is controversial whether it has real effect on bacteria that cannot hypochlorite achieve or not. Some articles, some authors advocate to use chlorhexidine in necrotic cases. You can use it; it's not a big deal. But remember, do not mix chlorhexidine with the hypochlorite. Always separate between them with normal saline or distilled water. This is the chlorhexidine. It has a broad spectrum of antimicrobial activity with sustained release. Sustained release means after we irrigate the canal with the chlorhexidine and after we dry it, the irrigant will work inside the root canal. It has little toxicity compared to hypochlorite. A chlorhexidine 2% has antimicrobial action similar to 5.25%. So once one will ask, if it has the same antimicrobial action as the hypochlorite, why not we use it instead of hypochlorite? Well, you can use it, but the problem is, who will dissolve the organic tissue, the vital or necrotic tissue? Remember, we use hypochlorite for this function, for this action. I have heard a few months ago that one of the companies claims that will use one irrigant and will cover from book to book, from cover to cover, all the properties of the irrigant solution. In fact, we do not have any irrigant solution till today that can dissolve organic tissue. Only hypochlorite. So if chlorhexidine will dissolve the organic tissue, we would use it instead of hypochlorite. But unfortunately, this is the only function of the hypochlorite. A more effective against Enterococcus faecalis, E. faecalis, and that's why we use chlorhexidine. This bacteria was found during failing cases, persistent infection, and after retreatment. So if you are willing to use chlorhexidine, and my advice for you is to use it for the failing cases, for the persistent infection, I mean with the periapical lesion, and even with the cases of retreatment. As I mentioned before, it is unable to dissolve necrotic tissue and remove the smear layer. So it cannot remove organic tissue and even inorganic tissue. It has only antibacterial action. Remember, if you by mistake mixed chlorhexidine and hypochlorite, we will have a very annoying precipitate. It's called parachloroaniline. This compound is cytotoxic in rats and carcinogenic in humans. I want to show you this video. What will happen if we mix hypochlorite with the chlorhexidine? The one in the bottle was hypochlorite, and we just throw a few drops of chlorhexidine over the hypochlorite, and you can see what happened. It will change like to tomato juice, and this is very sticky compound. It will stick to the root canal system, and it will be very hard to remove it. So what we do to remove this compound, this precipitate, if it happens, sometimes it happens. What we do, you can use alcohol, but alcohol would take longer time. The best solution for this is to use irrigant solution from Circaments. It's called Canal Clean. I forget to insert the photo. Canal Clean. It can remove this precipitate within a few seconds. Normal saline. We need normal saline in many times. Let's talk about the normal saline. We need normal saline to separate between the irrigants. We need normal saline after shaping procedures, but it should be cold. If you are using normal saline after shaping procedures, cold normal saline, a temperature between 2 to 4 Celsius, it will lessen the post-operative pain. If you are having hypochlorite accident, you need to use very cold normal saline. So normal saline is an important irrigant solution in endo. But remember, alone It has no antibacterial effect. It has no inorganic. It cannot dissolve organic tissue. It cannot dissolve inorganic tissue. But as I mentioned, you can use it to lessen the post-operative pain, the cold, normal saline. You can use it for hypochlorite accident, and you can use it to separate between the irrigant solution. What does not work for endo? What irrigant solution that cannot? What solutions that cannot be used for endo irrigation? Normal saline, aesthetic solution inside the carboys, sterile water, and if you are using hypochlorite and mix it with the hydrogen peroxide, this together, I mean, if you mixing hypochlorite with hydrogen peroxide, the hydrogen peroxide will buffer the hypochlorite, and you cannot make use of hypochlorite solution. Remember, don't let the hypochlorite or even the EDTA to stay too long inside the root canal. The major concern is the EDTA. You can leave hypochlorite like for an hour, as I think, but leaving EDTA too long inside the root canal will destroy the dentine wall. Okay, before I finish this lecture, I want to share with you my final irrigation protocol. If my followers and my colleagues are watching me on my Facebook account, the cases I share, most of the cases I share, it has lateral canal, it has many anatomies, and this is not because I'm experienced or skilled endodontist. The secret behind this is my final irrigation protocol I use every day in my dental clinic. Here what I use. Once I finish shaping and I'm ready for obturation, I start my final irrigation protocol. I start with the EDTA solution. I inject 2 to 3 cc or 2 to 3 ml inside the root canal, and then I activate it. You can activate with whatever device you have. You can activate it with the master cone Gatapirka. 100 times push pull can do it. It's better than nothing. You can use a subsonic activator like Endo activator, and you can use sonic activator like ED tip from VDW, or you can use ultrasonic activator like the one we use, Ultrasmart from Coxo. Do it for 30 seconds to 1 minute. It is better to separate and wash the EDTA with normal saline or distilled water. As I mentioned before, the EDTA will lessen the active chlorine in hypochlorite. But you can use hypochlorite directly, but increase the quantity. Okay? And then I inject 3 ml of hypochlorite inside the canal. Now time for heating. With the tip that I'm using for cutting the Gatapirka, I introduce it inside the canal, away from the apical tissue, 4 to 5 millim, and I start to heat the hypochlorite inside the canal till 200 Celsius for 1 to 2 seconds. Professor Alfredo Lilandlo says you can heat the hypochlorite inside the root canal for 8 seconds. I'm not following this protocol. I'm afraid of overheating the hypochlorite and damaging the periodontal ligament. Although Professor Alfredo says it is safe. So you can use whatever you want. You can choose whatever protocol you want. Personally, I only, for 1 to 2 seconds, I heating the hypochlorite. And then after I heat it, I do passive irrigation, passive ultrasonic irrigation. I activated the hypochlorite with the Ultrasmart device. And then you can repeat this step 2, 3, 4 till 10 times. Not a big issue. If you have a time, repeat the hypochlorite heating and activation till 10 times. You will have more anatomy. You will see more anatomy. And then, as I said, heating, activation, and normal sign. For necrotic cases, for persistent infection for retreatment cases, you can use chlorhexidine 2%. Remember, this is used for irrigation, not for mouthwash. The mouthwash is very diluted. Again, EDTA, Dremel, activate for 30 seconds or till 60 seconds. You can flush it with normal saline or distilled water, or you can use hypochlorite directly. Concentrated hypochlorite. Heated 1 to 2 seconds. You can heat it till 8 seconds, as Professor Alfredo say. And then activation again. Repeat the step. Heat. Activate it for 30 to 60 seconds. Flush all that with normal saline. Preferable to be cold normal saline. And then chlorhexidine if you have necrotic case or retreatment case or fading cases or persistent infection. Now, finally, I want to share with you this nice study done by Professor Alfredo Leandro et al., which is a very recent study in 2021. There was a comparison between different activation protocols. Syringe and needle, subsonic activation like endo activator from Dentsply, and sonic activation like ED tip from VDW, heating followed by sonic activation, and ultrasonic activation, and then heating followed by ultrasonic activation. The best thing was the heating hypochlorite and then ultrasonic activation. The less was syringe and needle. So the result was syringe and needle group showed the lower value of pulp tissue dissolution when compared to all test groups. Subsonic showed lower group tissue dissolution when compared to sonic and ultrasonic irrigation procedure. No difference were observed, not that difference observed between sonic and ultrasonic group. Pulp tissue dissolution was significantly higher when heating was followed by sonic or ultrasonic activation compared to sonic and ultrasonic group. So the conclusion is the better way to get maximum results and find and discover more anatomy is to heat hypochlorite and do sonic or ultrasonic activation. Finally, I want to show you some of my cases I use with the video. Before, I used to start with the hypochlorite then EDTA, but after the advice from Professor Alfredo, he advised me to start with the EDTA to to remove the smear layer and get a room and space for the hypochlorite to go inside these anatomies. Now I'm heating the hypochlorite. As you can see, and then I'm just activating the hypochlorite. One can see how the color of the hypochlorite will be changed to turbid color, and this mean the activation is done successfully. Repeat the step again. Fresh hypochlorite. This is my old protocol. Nowadays I start with EDTA and then hypochlorite, heating and activation. Again, I want to show you some of my cases with this protocol. See lateral anatomy everywhere. Isthmus, anastomosis, lateral canal, Lateral canals everywhere. Lateral canals. Lateral siblets, bifid. Lateral canal. Cul-de-sac, and so on. So thank you so much. Thank you so much for watching me. I'm done, and I'm ready to answer any question. Okay, does anybody has any question? Let me watch the...
Okay, thank you, Dr. Abra, so wonderful speech.
Anybody has any question? Okay, does anybody has any question? Let me watch the...
Okay, thank you, Dr. Abra, so wonderful speech.
Anybody has any question? Okay, does anybody have any question? Let me watch the...
Okay, thank you, Dr. Abra, so wonderful speech.
Okay, let's see the first question. Can we leave sodium hypochlorite inside canal between visits for more disinfection? No, this is not a good idea. This will affect the properties of the dentine. Please don't do it. Okay, how much is the optimum total amount and time of irrigation required for each root canal? Well, you cannot say, but my advice for you is to give a time between 20 to 40 minutes for irrigation. That means the irrigant solution will stay inside the canal between 20 to 40 minutes. Personally, after each file introduced inside the canal, I flush the canal with 2 to 3 mils of hypochlorite. Okay. According to the latest articles, chlorhexidine is very effective against the persistent bacteria. You mean mixing chlorhexidine with hypochlorite, or you separate with them with normal saline? If you separate, yes, but it is controversial. This is only stale articles. If you go to Mahmoud Turabinjad,
Okay, sorry, maybe Dr. Abra internet is not good now. Okay, let us choose the lucky person. Let us choose the lucky person who joined our course and comment on the video link. Okay, one. Okay, congratulations. The lucky person get our SC profile, she says. We will contact you soon. And thank you very much for watching this webinar. And thank you, Dr. Abra, this time. I have added a link for certificate on the comment. So if dentist friend who joined this course need a certificate, please fill this form information. Then we will supply for you soon. This link need to fill within 5 hours after the course. And thank you very much to join this time course of free public webinar. Hope to see you all again next week. Have a nice day. Goodbye.